Welcome back to part 2 of this special episode of Voices of Wisdom. I am Dr. Janice Pasieka, and if you just joined us, we are continuing our fascinating conversation on unexpected findings and challenges that surgeons encounter during surgery for thyroid cancer with Drs. Ashok Shaha from Memorial Sloan Kettering and Dr. Mark Urken from Mount Sinai. In this segment, we will explore further into this subject. If you haven't yet, I highly recommend listening to part 1 of our discussion to fully grasp the insights shared by our experts. So without further ado, let's dive right back in with our expert guests. All right. Well, let's move on to the next unexpected scenario. This probably happens more times than we like to think, and that is finding more extensive nodal disease. So Ashok, a similar patient, 3 centimeter, a few lymph nodes were seen in level 6, but no lateral disease. The plan was at least a lobectomy and to see if these nodes were truly positive. However, when you get in there, the central compartment clearly has positive nodal disease. Now what?
Okay, so every patient who goes to the operating room and there is a concern like 3 centimeter thyroid cancer, there's a concern about central compartment nodes, there is a concern about lateral nodes. And the patient and the family should be prepared that I will change the operation based on what I see at the time of surgery in the best interest of the patient. So the $1 million question is, does this patient require radioactive iodine? And if there are, let's say, 6 nodes in the central compartment, there are a couple of nodes in the lateral, you know this patient is going to need radioactive iodine. And I would convert the operation from lobectomy to total thyroidectomy, do a good ipsilateral central compartment clearance, look at the opposite side, do a good thorough evaluation. If there are any lymph nodes on the other side, take them out. Those are the cases where I'll be very careful about the superior parathyroids and be prepared. Every patient who goes for lobectomy should be well informed, including the family, that I may change the operation in the middle of the case and may do a total thyroidectomy so that you don't have to come back for a second operation. I think the patients understand that very well, especially I'm talking about the borderline cases. I'm not talking about 1.5 centimeter or 1 centimeter thyroid cancer. 3 centimeter is truly a borderline. I'm concerned about the nodal disease that you may not be able to see. If there are more than 5 nodes or larger nodes or gross disease, I would do a total thyroidectomy same time.
Mark, do you have a similar approach?
I do. And so, we all have that magical number of 4 centimeters in our mind that if the tumor is less than 3.99, then they're going to qualify for a lobectomy. But I think as you get larger up to that point, you need to be prepared for, and you need the patient to be prepared for converting to a total thyroidectomy. And I would agree, lymph nodes, you should do your best to clear those nodes, because going back in, we all do it if need be, but it's always easier the first time around here.
Right. And if the lateral compartment was negative on your ultrasound and you don't see anything, just do the central. You can always go back into you don't really want to be dabbling in the lateral compartment looking. Would you agree with that?
100% agreed. And that's why, again, I'm going to bring up a good preoperative evaluation. The majority of the recurrent cancers or recurrent nodal disease are the persistent disease due to under-evaluation during the first operation.
So, Mark, you have a similar patient, but this time you find the recurrent laryngeal nerve is completely sort of encased in these bulky lymph nodes, and you have a good signal. You know the nerve is functioning. How do you approach this? How do you preserve the recurrent laryngeal nerve at all cost? Just take me in the operating room of what you're doing in trying to get this bulky disease out.
I think it's not only those bulky lymph nodes, but obviously extrathyroidal extension that could put you in the exact same scenario here. And I think that if you have a good signal, and these are cases where intraoperative neuromonitoring is going to be extremely useful, you're going to fight like hell to keep that nerve intact. And And as long as the nerve looks healthy, and there are times when you may see that a nerve has either has become swollen or has a different color in proximity to that gross disease, those are situations that I'll treat slightly differently. But you're gonna work extremely hard that day to use every skill that you have in your armamentarium to preserve the integrity of that nerve, even as the Japanese have shown that you can actually take some of the circumference of the nerve and preserve some of those nerve fibers. That can be very valuable. And so I think it's very difficult to sacrifice a functioning nerve, especially when you don't know whether you can actually salvage that situation with postoperative adjuvant radioiodine.
And it's not uncommon to find these nodes right at the insertion of the recurrent laryngeal nerve, sort of tucked in behind. And that's another place where this, when we get recurrence or persistent disease. Any tricks of getting those?
Yeah, that's another situation where I'll scrub out, I'll get on the phone with Dr. Shaha and say, Ashok, here's my situation. What the hell do I do? I will, it's all part of the same thing here, where you are, you've got your loops, you're looking at this critically. It's really important to do this, this type of surgery with magnification. And same technique, you'll use sharp dissection, get the nerve off to your very best ability. Even situations sometimes where I will track the nerve through disease. If it's rare and you hate to, usually it's on the surface of an extra thyroid or extra nodal extension, but sometimes I've had to do that. And but you're putting the nerve at greater and greater risk the more that you do to it.
Yeah. Ashok, do you have any pearls at that insertion?
Yeah, 2 points. The nerve may be adherent to the lymph nodes, which is generally not very difficult to separate, especially in young people, unless it is a truly aggressive, poorly differentiated cancer. The two instruments that help, one is a micro clamp, and they are in the plastic set. Whenever you are doing this surgery and you have a very difficult problem, ask them to open the plastic set. And they also have a bipolar, which is a plastic bipolar they use for the microvascular flaps. It's like, and a Castroviejo Caesar, you can cut in the perineurium and get the tumor off. Now, very important, if you are going to do that on one side, look on the other side. Is the disease similar on the other side? Especially in these young people with diffuse sclerosing variety, you resect or do the best operation on one side, you lose the signal on one side. Now it becomes emotionally traumatic to go on the other side. So be careful. In young people, let's say there is a primary tumor, which is adherent to the nerve. You can core the nerve out, as Mark said, and then use radioactive iodine as an adjunct. I'm talking about the young people. It works very well. But if you're going to do it on one side, make sure there is no similar disease on the other side. And it doesn't take much to look on the other side, be prepared. I mean, we talked about the lymph nodes, but if the primary is in the posterior portion of the thyroid, especially elderly person, the tumor may be engulfing the nerve and you have to make a critical decision. Do I need to sacrifice the nerve for better control of the disease? Because if these people recur in that area near the ligament of Berry, the salvage is very difficult. So be prepared to do the best operation first time. If you have to take out one nerve, majority of the time the patients will recover very well. There's a little bit of help from laryngologists will help. But if you're going to sacrifice a functioning nerve, you have to have a feeling that I'm going to do the best curative operation today and not leave the tumor behind. The goal is not to leave the tumor behind.
Right. So, I mean, that is always a very emotional thing for surgeons. You're in there and then all of a sudden you have a functioning nerve, but the tumor is completely encased in it. And you know that if you're going to leave disease behind. Mark, how do you approach this? Like it's a functioning nerve you're going to have to sacrifice it to take out the disease. Give us some advice as to how we can get over this trauma as a surgeon to cut a functioning nerve.
Yeah, it is. I agree with all that's been said here. And I do think that there is some value in this situation, not only the value of intraoperative neuromonitoring, but also in this situation, I'll go to the other side and actually do that other lobe, convince myself that I have preserved that other nerve. And then I can come back with much greater confidence and do the resection that's needed and sacrifice that nerve. Being prepared at the same time to reconstruct that nerve with usually my choice is the ansa cervicalis. And so I'm ready to do that. And that same plastic set with all the micro instruments that can come in very handy in that situation.
One other point, Janice, I learned from one of my colleagues here at Sloan Kettering, always get one of your colleagues to come and look at this nerve and make sure that they concur with you so that you can take to the family and say, hey, I was doing the surgery. I saw this bad tumor. I thought this would be important. And I called Dr. Pasieka or Dr. Urken and they agreed with me. And many of my colleagues would say, can I write your name that you came and saw the patient? I said, fine. Again, we're trying to do the best for the patient. And if there has not been discussion before, again, scrub out, talk to the family that, look, this is what I need to do. I hope you agree with me. I'll do my best. Again, when Mark said it very well, when you approach the family and tell, I want to do the best cancer control, they will agree with you.
Yeah, and I think another scenario for maybe the community surgeons or those that don't have colleagues at their fingertip like you both have, maybe taking out that one side and leaving the other side without disrupting that nerve and sending for a completion thyroidectomy in somebody that is much more confident that they're not going to injure that nerve or has other tools. That's not a bad approach if you have to, when all is said and done. Well, I think let's summarize what we've had to say today. So cross-sectional imaging preoperatively should be done when, Ashok?
Larger tumors. I'm giving a very vague answer. Let me change that. Any tumor that I can feel.
Any tumor you can feel.
Because that has to be about 1.5, 2 centimeter or a hard tumor. Or again, my philosophy is I want to see the three-dimensional view. And many times the patients say, why I need to get a CAT scan? Am I going to get a lot of radiation? Tell them there is a minuscule radiation. I get more information that is helpful to me. I would add one more thing. In medullary cancer, do get a CAT scan because there are pretracheal lymph nodes, superior mediastinal lymph nodes that you're not going to appreciate till you go in the operating room. So I would definitely get a good preoperative evaluation. I would discuss with the family quite a bit about the extent of thyroidectomy, the pros and cons. And it's not just the patient. I like to get the family involved because it's the family who is going to notice the complications, not the patient.
Okay. Mark, tracheal resection should be considered at the primary operation when?
When you've proven that the disease is documented in the wall of the trachea, you see that you can't get a clean resection with a tracheal shave, then your best opportunity to clear that disease is in the primary setting. And you need to be comfortable in doing that.
And you need to be comfortable, yes. Or call in a friend, send it to a friend. I think we'll all agree that we always need to be prepared for nodal disease, whether even though it tells you there is none, always be prepared. Preservation of the recurrent laryngeal nerve should be done at all cost when? Ashok.
Almost every case, if it is functioning preoperatively, unless you feel two things. The tumor is encircling the nerve and you cannot core it out, or older patient with a very aggressive tumor. I think there I would be more generous to sacrifice the nerve. And the third thing is the surgeon has to feel when I'm coring the nerve out of the tumor, I'm not leaving any gross tumor behind. Because the worst thing in these cases is leaving gross tumor behind. When that tumor recurs, it's in the cricothyroid area or near the junction of the first ring and the cricoid cartilage, which is surgically very difficult to resect later on.
And Mark, sacrificing a functional nerve should be considered when?
When you've exhausted all options of preserving that nerve and that you're confident that the opposite side is intact, and you've documented that with intraoperative neuromonitoring. Can I just add one more caveat? Ashok, do you mind if I include your cell phone as part of this broadcast? Just because it's a very helpful piece of information if you're in those really difficult situations here.
Yeah, but I think that is an important one. Call in a friend, a colleague to really just sort of help you with making the right decision for your patient.
See, 80% of the time, the thyroid surgery is a straightforward lobectomy, total thyroidectomy. It's those 20% where we get into trouble. And some of those when you examine the patient, you get a sense. Sometimes the imaging will help you. Sometimes the sonographer will say, hey, this looks very bizarre. The tumor is in the posterior part, abutting the trachea. I would get cross-sectional imaging. And if you feel that this is not your cup of tea, don't be shy. Call a friend. That, look, I'm sending the patient to you. Again, what we're trying to do is the best control of the disease, the way it has come to us.
Gentlemen, this has been fantastic and a very informative discussion. But before we wrap things up, I thought we should end each of our podcasts with a little extra knowledge for our listeners, something that goes beyond medicine and take advantage of our international reach. You have both had the luxury of traveling and visiting many places in the world. So can you tell us what your favorite place in the world is to visit and why? Mark?
Gosh, great question. Probably one of the great perks of being in academic medicine and having the ability to travel. I think if there is a chance, and I suspect there is, that my wife is going to be listening to the podcast, the answer to that question is wherever the heck she wants to go. I'm sure that Dr. Shaha will agree. But there's so many different places in the world. We have a particular affinity for Italy, just because of its history and its magnificent food here.
Fantastic. Ashok, where would you go? Where would you send me?
I've gone to many different parts of the world for meetings, etc. I've gone to Italy about 25 times. I've gone to Brazil about 12 times. I still love to go to Rio de Janeiro. I think it's a beautiful place, very robust. You feel young there. And one thing that I still love to go to is India. Even though I come from India, I was born in India. There are so many places in India that I have not visited. And every time I go, it gets better. The hotels are great. The food is obviously, food is wonderful. But the hospitality you get, and when you give a lecture, the reception you get from the audience, they are so happy. It makes you feel good and fulfilling in your academics. So, Janice, I have a question for you. You have traveled too. What is your favorite place?
Yeah, so that brings us to the end of our podcast. Voices of Wisdom on unexpected findings in the operating room. I want to extend a special thanks to our distinguished guests, Dr. Shaha and Dr. Urken, for their invaluable pearls of wisdom. If you have any questions or suggestions for future podcasts, email us at voicesofwisdompodcast@gmail.com. And if you liked our podcast, please subscribe to our webinars, which air live every Friday morning at 8 a.m. Eastern Time. This is a series for thyroid clinicians and researchers that cover breakthroughs in thyroid cancer research and treatment in the form of journal clubs, state-of-the-art lectures, multidisciplinary tumor boards, and a lively panel discussion. Just visit tyro.expert/subscribe or click on the link in the description. Stay tuned for future episodes, including those on active surveillance, the role of molecular testing, and addressing the rising thyroglobulin level, to name a few. I want to thank you all for joining us today, and I want to leave you now with a quote from one of my heroes, Sir William Osler, who said, "A good physician treats disease. A great physician treats the patient who has disease." Reflect on that today when you're seeing your patients in the clinic. And with that, thank you very much.